I have the pleasure today of opening the session and introducing the speakers for the finalists for the Mitchell-Max Award. Since 2009, the Pain Consortium has presented the Mitchell-Max Award for research excellence to an outstanding junior investigator. This award is in honor of Dr. Mitchell-Max for his lifetime contribution to pain research. And I'm sure many of you in the audience remember Dr. Max very well. His contributions were vast, his personality wonderful. And I think we all miss him greatly at NIH and probably everywhere else. The Pain Consortium poster session features investigators at early stages of career development, either NIH fellowship, NIH or some type of career development awardee, or just independent, first independent NIH grant, such as an R03 or R01 or an R21. Representation from the NIH Pain Consortium representatives reviewed these submitted abstracts to this poster session, and the top 3 investigators were invited to make oral presentations at this session this morning. The first of these I'm going to introduce now, and that's Dr. Fadel Zeidan. Dr. Zeidan is a postdoctoral fellow at the Department of Neurobiology and Anatomy at Wake Forest School of Medicine. He received his PhD from the University of North Carolina, Charlotte, in experimental health psychology. He employs psychophysical, psychological, and emerging neuroimaging methodologies to identify the behavioral and neural mechanisms that mediate the relationship between self-regulatory processes and health. Very pertinent to some of our discussions we've already had this morning. His current programmatic line of research is focused on disentangling the specific analgesic components of mindful-based pain relief. And his presentation is titled Neural Mechanisms Supporting Mindfulness-Based Pain Relief as Compared to Placebo Analgesia. Dr. Zeidan?
Thank you so much.
You're welcome. Let's see, your presentation's up. Here's a pointer and make sure you're speaking.
Okay, great. Is this the clicker? Okay.
Yeah, that's the clicker.
Okay, great.
Sure.
Good afternoon, I think. Good morning, maybe. I'm delighted to be here. I am honored to have been selected as a young investigator presenter. I'm delighted to just talk about our latest findings associated with neural mechanisms supporting meditation-related pain relief as compared to placebo. As you all know, chronic pain has been characterized as a silent epidemic, affecting over 100 million Americans and 1.5 billion people worldwide. Medical treatment, lost productivity costs the United States approximately $635 billion a year. These staggering statistics really demonstrate the importance of testing, developing, and validating alternative approaches that are cost-effective and not addictive, such as mindfulness meditation. So why would we study mindfulness and pain in the first place? Well, mindfulness has been associated with enhancing acceptance-based coping strategies, improving mood, engaging cognitive reappraisal processes, as well as improving cognitive control and emotion regulation strategies. These are all mechanisms that have been found to mediate the cognitive modulation of pain. So for the last 13 years, what I've really done is focused on trying to isolate and identify the health-promoting and analgesic components of mindfulness meditation. And I've done this by employing a brief mindfulness-based meditation intervention. Generally speaking, what we do is we recruit healthy people, and they undergo 4 days, 20 minutes a day of meditation training. So just in brief, what we teach our participants to do is to focus on the changing sensations of the breath. Whenever their mind drifts away to an emotion, a fleeting feeling, some other sensory event, they're told to acknowledge it and to simply let it go without any further judgment and or evaluation, and just to gently bring themselves back to the breath. and they're essentially supposed to just repeat this over and over. So they really hone in on these skills across only 4 days, 20 minutes a day. And remarkably, we have found that this technique can significantly reduce anxiety, depression, obviously mood, as well as other health outcomes. And as of recently, we've been able to identify some of the specific neural mechanisms involved in meditation-related pain relief and anxiety relief. However, we've seen this massive surge in mindfulness-based research. I think last year there was over 550 publications on mindfulness research, which is a dramatic increase when compared to 10 years prior. But we still have not addressed whether or not mindfulness meditation reflects components related to relaxation, divided attention, components of placebo analgesia, such as modulation of expectations, as well as conditioning, and demand characteristics related to the established beliefs of meditation's health-promoting reputation. So the golden standard for clinical trials is to test whatever the treatment is against a placebo or a sham. And to date, we have not done this. And that's what the focus of this project and this experiment I'm going to talk about today is. So quickly, I'm going to go over the methods and procedures. In our laboratory, we evoke pain by employing noxious thermal stimulation using this TSA thermal probe. And in this case, we employed 10 12-second plateaus of 49 degrees Celsius across 6 minutes. And we measure 2 dimensions of pain intensity and pain unpleasantness with this visual analog scale, anchored from 0 is no pain, 10 is worst pain imaginable. And we employ neuroimaging with an emerging fMRI technique known as arterial spin labeling. This is a perfusion-based fMRI technique that allows us to directly quantify regional as well as global cerebral blood flow values. Furthermore, it allows us to assess and control for potential respiratory-related confounds that may arise from steady cognitive states such as mindfulness meditation. So in this ongoing project, we randomly assigned healthy, pain-free participants to a mindfulness meditation intervention / group that I just described, a placebo conditioning intervention, a sham mindfulness meditation intervention, a book listening control regimen, and this experiment required over 600 individually tailored experimental sessions, 7 sessions per subject. I did have hair before I started this experiment. So the placebo group, I described to you the meditation group. What we told our participants in this group is that we were testing the effects of a topical analgesic experimental cream called lidocaine, and that the reason that this cream was experimental is because its analgesic effects get stronger progressively over time. So in the first placebo conditioning session, we asked our participants to come in, and we stimulated the back of the left calf for 6 minutes at 49 degrees Celsius. Then we applied and removed this inner cream. Here is the way we presented it to our subjects without this tub, but it was mostly petrolatum jelly. And after 10 minutes, we removed the cream and covertly reduced the temperature to 48 degrees from 49. The next 2 sessions, sessions 2 and 3, after we removed the cream, we lowered the temperature to 47 degrees. And in the final conditioning session, we lowered the temperature to 46.5 degrees from 49. We did this to lead our participants to believe that the cream contained analgesic properties and to lead them to believe that the cream's effects get stronger over time. And we measured the placebo effect, if you will, in the post-intervention MRI session, where after we applied and removed the cream, we ramped the temperature back up to 49 degrees. The aim of the sham mindfulness meditation intervention was to lead our participants to believe they were practicing mindfulness meditation when in fact they were not. So we told our participants that they were randomly assigned to the meditation group. Every day they came in and were instructed to sit with their eyes closed, straight posture. And every 2-3 minutes we asked them to take a deep breath as we sit here in meditation. In essence, the only difference between the genuine mindfulness and sham mindfulness meditation group were the explicit instructions to focus on the breath, to practice mindfulness, if you will. In fact, we even matched the time spent providing instructions between the sham and mindfulness meditation groups. The control group came in and listened to the natural history of cell-borne and audio recording, which some may argue was a pain manipulation in itself. And so we employed this group to control for facilitator attention as well as the time that had elapsed in the other group's interventions. Importantly, the thermal stimulation procedures that we employed in the placebo group were also matched across all the other groups. Okay, and we did this to make sure to control for habituation and sensitization effects. Okay. So we have a ton of outcome measures, but for this sake of time, I have behavioral pain ratings, mindfulness scores as measured by the Freiburg Mindfulness Inventory. We administer this before and after each respective intervention, as well as neuroimaging results. First and foremost, we see that mindfulness was the only group that was able to significantly improve in mindfulness scores, a significant increase of 16%. And the sham meditation group virtually was left unchanged. So this demonstrates that our mindfulness meditation intervention was unique at cultivating the state of mindfulness when compared to the rest of the groups. Let's move on to the pain ratings. This is a very simple depiction of the pain intensity ratings. On the y-axis is the percent change in pain intensity. X-axis is our groups. First, all of our groups were the same on pain, i.e. there were no significant differences at baseline pain ratings before the interventions. So that's important. All of our cognitive manipulations, placebo, sham, and mindfulness meditation significantly reduced pain when compared to the control group. However, mindfulness meditation was significantly more effective at reducing pain intensity when compared to the rest of the groups. Now, to put this into perspective, Don Price and colleagues in the 1980s, employing the similar thermal stimulation paradigm and the same VAS scales, found that one clinical dose of morphine reduces pain by, on average, 22%. So these effects are not trivial. And the same story is depicted for pain unpleasantness. All of our cognitive manipulations significantly reduced pain unpleasantness when compared to the control group, but yet again, mindfulness meditation reduced pain significantly more than the rest of the groups. And it's also important to note that sham meditation was very effective at reducing pain unpleasantness by 24%. Let's move on to some of these images. What we have here is the main effect of meditation, main effect of placebo, and the contrast between these two. And there's a lot of data here, but I just want you all to focus on the fact that there was significant deactivation of the periaqueductal gray matter, a brain region implicated in descending control of pain as well as facilitation of pain, and the thalamus, widespread deactivation of the thalamus. And this came out as significantly different, i.e. there was greater activation in the PAG and thalamus in the placebo condition when compared to meditation. And there's a similar story here when compared to sham meditation. We see that there's greater activation in thalamus and PAG when compared to meditation, and that mindfulness meditation actually activated brain region ranging from the perigenual ACC to the medial prefrontal cortex, brain regions that are heavily implicated in cognitive control of pain as well as emotion regulation strategies. So, taken together, we see that mindfulness meditation-related pain relief is more effective than sham mindfulness meditation and placebo analgesia. And we see that mindfulness meditation significantly deactivates the thalamus, a brain region that's crucial in sensory processing, in mediating lower-level afferent processes, as well as deactivating the PAG, a brain region that's heavily implicated in facilitating pain transmission. So based on our previous findings, we postulate that meditation attenuates pain through multiple mechanisms, that placebo likely engages descending control of pain, and based on some other preliminary data, we postulate that sham meditation-related pain relief likely engages placebo as well as relaxation-related mechanisms. So the take-home here is clinical efficacy if the effects of meditation can be realized almost immediately. And found to be more effective and engage distinct mechanisms from that of placebo and sham meditation, then this technique may prove to be more attractive to clinicians, patients, as well as health insurers to treat pain. I have to acknowledge the members of Dr. Bob Coghill's Brain Mechanisms of Pain Laboratory, and this work cannot have been done without the support of NIH's National Center for Complementary and Alternative Medicine, the Mind and Life Institute, and Wake Forest School of Medicine. Thank you so much for your time and attention. I think we have time for some questions. If anybody's interested.
Annemieke Kavelaars from MD Anderson Cancer Center. Very nice work. My question is, when you think about the clinical translation of your work, because what I understand is that you rely on basically teaching these individuals that their practice works by reducing the temperature over those 4 sessions. So that would mean that if you want to apply it clinically, you would have to have a drug that works in the patient group before you can use it, or do I misunderstand the setting?
We covertly lowered the temperature for the placebo conditioning intervention. We did so for the meditation group just to match the thermal stimulation paradigm, but we used no instructions in the meditation intervention related to pain. So we just taught them basic mindfulness skills, and it was totally independent.
I understand, but over the period of the mindfulness training, do they know that you give them a lower temperature, or do you say that you give them the same pain stimulus and they now rate it lower because it's actually a lower pain stimulus?
We lowered the temperature without telling them we lowered the temperature, but in the fMRI session, everyone received 49 degrees Celsius.
Yeah.
So, and they were not meditating during the reduction.
No, I understand.
Okay.
Okay, thank you.
Okay. Yep.
Jay Park from UNC Chapel Hill. The reduced the PAG signal, could we interpret that those who have meditate, they have better inhibitory control of the pain signal, so that it doesn't send any more like a sensory signal to our pain recognizing kind of pathway? Could we interpret that way?
We're getting there. We have to do some more post-hoc analyses, but what we're seeing is that there might be a downregulation from orbitofrontal cortex and other PFC regions that downregulate lower level regions in the brainstem and the thalamus. So we postulate that it may serve as more of a gating mechanism associated with more of a cognitive reappraisal approach to this noxious experience. Hi.
Luana Coloca, very interesting study.
Thank you.
I have a question. You did the manipulation to make these people believe. Did you assess expectancy?
We did.
The second question is, if you manipulate in both the groups, placebo analgesia and meditation, the pain intensity, I'm not surprised that you observe a larger analgesic effects under meditation, because it's a combination of learning plus meditation. So in this case, your study cannot address the mechanism of placebo analgesia against meditation, because you use the same learning paradigm for both the group.
In the sham meditation group?
Yes.
So the sham meditation and the mindful...
Start with the expectancy.
So we measured expectation of pain relief, and we found that we didn't run a relationship yet with the regression. We just finished these analyses. We didn't run a regression between expected pain relief and actual pain ratings, but we found no differences in expected pain between the sham and the mindfulness meditation group. So with the second question, we looked with sham and mindfulness meditation, everything was matched except the mindfulness component. So we tried to match everything to really pull out the mindfulness effect from the meditation group as compared to the sham group. And so do you want to elaborate more on the question?
The point is, if we do the same manipulation for pain intensity, I mean the reduction of pain intensity to make people believe that the procedure was analgesic, if you do the same in the placebo group and in the meditation group, what you will get at the end in the meditation group is the summation of both learning mechanism plus meditation effects. And my concern is that if you do this, it becomes very hard to distinguish the pure mechanism of meditation from placebo analgesia and learning.
Okay, maybe we can come talk about this at the poster. Yeah. Thank you so much.
So you could come by and see Dr. Zeidan's poster and talk to him a little further about that. We're going to move on now to the next presentation. This presentation is by Dr.